As a pathologic point of view, would you tell us what structural feature predict plaque vulnerability?
You know, plaque vulnerability is a term which has been used in many different ways. They've used the term to say a patient is vulnerable to have a plaque atherosclerosis. Others have used it to say that this is a lesion that is likely to rupture. So we use it in that term, that this is a lesion which is likely to rupture. Now, what are the features? They are totally based upon the same features that we see in plaque rupture. So those are features of a necrotic core. It has to have a fibrous cap, which is thin, which is less than 65 micron, and it is infiltrated by macrophages and T cells. And there are very few smooth muscle cells, and the cap is made up mostly of type 1 collagen. There's very little proteoglycan in that cap. So those are the features. Now, what makes that vulnerable plaque rupture is a $1,000 question. None of us know an answer to it, as yet.
In the clinical practice, it's not easy to define how big necrotic core or how thin fibrous cap is vulnerable plaque. So, based on your pathologic studies, would you give us your perspectives on this matter?
Yes. I mean, necrotic core, obviously, we can define it better than you can in a way. You're relying, OCT has very nice imaging, in a sense, it's 10 to 15 micron in resolution, whereas when you look at IVUS, it is much more than 150 micron. So therefore, there is a limit to what you can really put the outline to. We've looked at our ruptures, and overall, we can say majority of the ruptures have a large necrotic core, and that's about 35% on an average of the area of the plaque is occupied by a necrotic core. Whereas when we look at our vulnerable plaques, it's only 25%. So I think if we were to take all vulnerable plaques that are more than 35%, maybe we will be better off being able to tell what is that makes it rupture. So I think that combinations of things. It's also the necrotic core, how big the arch is, in a sense, how much of the circle does it involve? Is it one quadrant 90 degrees or is it 180 degrees? When we measured ours, it was about 120 degrees. So I think the bigger the arc, the longer the necrotic core, and the thinner the fibrous cap, and the length of it is also important, which we haven't done, because you need serial sections to do it. Whereas for you all, it's much easier. You should do it, the clinicians should do it by OCT and be able to say that when we look at serially from proximal to distal or distal to proximal, that what is that length of that thin fibrous cap? Does it go on, say, 1 centimeter? Is it 2 centimeters? And how much of that circumference is involved? And I think those are important. Also, people are saying that calcification is important in the fibrous cap. So I think that's another thing we should look at. Even the necrotic core calcium is important. When on the abdominal side you get calcium. In our cases, when we look at our plaque ruptures, good 80% are calcified. 20% are not calcified. So we should look for calcium, and that may also help us say these are more likely to rupture than those without, because I think this has to do with the fact stress strains will be different in a plaque which is calcified versus a plaque which is not calcified.
CVRF constantly have published about pathology findings in relation to thrombotic disease. Would you explain the mechanism of plaque progression and what will be the next target for a new drug to stabilize the plaque?
Plaque progression is a complex disease. Obviously, we in pathology at autopsy, it's one stationary. And so we are making a story out of it. So when I look at these, the way I understand is I think the earliest lesion of atherosclerosis is pathologic intimal thickening. And when it starts to get macrophages in its, towards the lumen, towards the fibrous cap, I think they have lipid pool. Lipid pool is different from what we call as a necrotic core. Lipid pool contains lipid plus proteoglycans. And the proteoglycans that are there are the ones, versican is there, and there is hyaluronan, which some say is not quite a proteoglycan because it lacks sugar. So when you look at those two, as long as they are present in early necrotic core, we say the progression from lipid pool goes on to form an early necrotic core. How that occurs is macrophage infiltration occurs from the lumen site into that lipid pool, and those macrophages start to die in the site of the lipid pool. They start forming, digesting the proteoglycans. So what happens is eventually it's a graveyard of dead macrophages that forms the necrotic core. There is no matrix. That is, no more do we see proteoglycan, we do not see type 3 collagen, we do not see any collagen whatsoever. So it's like a paste in there. So there's no really structure to it. That is a necrotic core. And for the vulnerable plaque, you have to have that type of necrotic core. So we think it progresses from pathologic intimal thickening, macrophages come in, they lead to early necrotic core when macrophage infiltrate that lipid pool, try and convert it into a necrotic core. Then we call it late necrotic core, when the whole necrotic core is made up of this now dead macrophages, or there may be some hemorrhage as well. And then comes the phase of hemorrhage. You get much more hemorrhage in that necrotic core, it becomes larger, and the fibrous cap begins to thin out. And then eventually it becomes a thin cap fibroatheroma, and then it eventually ruptures. But of course, while it is undergoing all this, there is calcification occurring in the dead macrophages. They undergo calcification, and also the area around that necrotic core starts to calcify. That is the collagen as well as smooth muscle cells. So those are things that eventually lead to, now when it ruptures, it'll form a thrombus. It can be silent. Most of the time, beyond a 40% narrowing of the vessel, it narrows beyond that only through repeated ruptures. And those mostly are silent. They do not, only in our hands, we've seen only 10-11% of our ruptures are virgin ruptures. That means they've never ruptured before. So if they have ruptured once, then they are no longer virgin. If they are rupturing the first time, that's a virgin rupture. And we find that you can get up to 4 rupture sites within that same areas, within that same plaque. So that's how plaques become, or vessel gets narrowed and plaques enlarged, is I think from repeated ruptures. So but there are others which also narrow the vessel or plaque burden increases. That occurs from fibrous tissue formation. So now this last question you asked me was, what is the next target? Now, I think the next target is still macrophages. I have to say macrophages are an important part of it. Some people would say T cells. For me, I think the more important is the macrophage. If we can reduce both macrophage and T cells, I think we could actually reduce the amount of burden. Now, the destruction occurs from cells. The destruction doesn't occur from just lipid alone, because lipid comes into the vessel wall. How does that vessel wall get destroyed? It gets destroyed from cells. So the cells are our biggest enemy in atherosclerosis. So we should try and see that they decrease the number of cells that come into it. So my target still would be macrophages, I would say.
So do you have any result of this kind of study now?
No, there are studies which are ongoing that they are doing methotrexate. They're using methotrexate to reduce, because for example, in rheumatoid arthritis, they have shown that the disease smolders if you give low-dose methotrexate. So Paul Ritker is trying this. He's got a large study that he is ongoing study with methotrexate. He's treating people with ACS with methotrexate. Now, there's another study that he's doing, which is IL-1 beta. It's antibody to IL-1 beta. Another one, is Durapidil, which is LPPLA2 inhibitor. So that's another drug which, again, it targets the macrophages, because macrophage cell death won't occur because it occurs through the breakdown of oxidized LDL and PC through the LPPLA2. That oxidizes it, leads to oxidized PC. This oxidized PC causes cell death of macrophages. So it's targeted to reduce the amount of LPPLA2 that will be available to the plaque. So that's another way of doing it. But there are people who are making vaccines. So that's another target, is through T cells. So it's still an ongoing process. I think there's still many years before we learn everything.